and welcome to the Spinal Cord Injury Forum. My name is Jeannie Hoffman. I'm a clinical psychologist in the Department of Rehabilitation Medicine and the director of the Northwest Regional Spinal Cord Injury System here at the University of Washington. Tonight, I'm very pleased to welcome two guests, Dr. Katerina Radkevich and Elaine Stefanowicz. And they're going to be sharing their experience as both a spinal cord injury physician and then a person with spinal cord injury as they relate to heart, weight, and nutritional health, and really giving some of their own personal recommendations and advice about how to make healthy lifestyle changes. So thank you for joining me tonight. Last month, I wanted to just preface this by saying that we learned really about the new clinical practice guidelines for cardiometabolic health. And so this month, we really wanted to switch that and getting advice from the people who are in the day-to-day work of putting those into practice. And so the two guests I'm going to have introduce themselves. And actually, Dr. Radkevich, if I could start with you, that'd be great. Can you talk a little bit about your work, your spinal cord injury physician at the VA, and tell us how you got started in this work?
So well, as stated, I'm a physician at our Seattle VA, and I am board certified in physical medicine and rehabilitation, which is also known as physiatry, and then I'm board certified in spinal cord injury medicine. So I did my fellowship here in Seattle, and before that, my residency in the University of Michigan and medical school in New York before that. That's my kind of general background. And then should I talk about how I got interested in weight loss now? Okay. Exactly. So it was kind of a little bit of a personal and professional accident in a way. I have a friend that we've been going to different conferences. She joins me a lot for my physiatry conferences, even though she's an internal medicine physician. And one year she said, "Oh, I'm going to this obesity conference in DC. Would you be interested in coming with me?" And my thoughts at that time was like, well, that's very narrow specialty topic. I wasn't entirely certain that that would be a great idea and that would actually, my job, the VA, would allow me to go. So I talked to my boss at that time, and he's like, well, actually, that's a great idea because the cardiometabolic guidelines were just coming out later that year and said that would be a good idea to go. So I did, and that's how I got interested in this fascinating topic.
And it's not something that everybody just picks up.
Yes, I think most of physiatry residency programs don't necessarily pay a lot of attention to weight loss and weight management. Partially it's because it's there are lots of other things to cover that are a little bit more specific and obvious for conditions that are common in physiatry. Spinal cord injury, brain injury, strokes that are more specific, such as spasticity, differences in mobility, and I think obesity and metabolic changes are often considered to be more of internal medicine topics and specialty, something that a primary care provider would discuss. And I think it just maybe overlooked or not really emphasized.
Yeah, that's great. So Elaine, could you do your introduction? Tell us a little bit about kind of how long you've been injured, what your injury level is, and kind of what brought you to this discussion with us today.
Yeah, thank you. I appreciate being here. I've been in a wheelchair since 1982. I was a junior in high school, into my junior year, and was in a car accident in Puget, Washington, and yeah, I was at Good Sam Hospital actually for my rehab there. And back then you were in for 5.5, 6 months if you were a para, and a year if you were a quad. So it's kind of a different world now. And so you had a lot more kind of hands-on learning about things, but weight is always something that I've struggled with even before my accident, and I'm, Eskimo in a wheelchair, really God, thank you, and so it's always been something, that I've struggled with. I'm a carb addict, and it's always been something, convenience eater, fast food, that kind of thing. And so in 2008, I became a type 2 diabetic with kind of my yo-yo dieting, and I've lost my gallbladder because of dieting, and so yeah, it's been something I've struggled with for a long time.
So tell me a little bit about kind of where you started this journey in terms of kind of changing your health and really addressing all this, because you kind of like do the tick marks for kind of cardiometabolic syndromes and difficulties.
Yeah, it's pretty common, and I'm Native too, so that seems to be another thing for people with diabetes. I was at risk for a lot of different reasons, and but it was still a shock. I thought I had chronic fatigue syndrome because I literally could not keep my eyes open when I was teaching a class one time. I was thirsty all the time, and then I went to the doctor, and they gave me insulin immediately because I think my blood sugar was over 300, and my A1C, which is your blood sugar over 3 months, was like 10.5. So they started giving me insulin, and I had to go through all the nutrition classes, but it really didn't kick in until probably 3 years ago. And when I was 52, I decided to do a thing, just my own my own little, I don't know, branding of Healthy You 52. And and I just decided to make a lifestyle change. And for me personally, Weight Watchers has always been something that I've called myself the prodigal daughter of Weight Watchers, because it's always the one that, I guess it's real. You can eat anything, you just have to count it. And me personally, I like the community aspect of going to meetings and having someone other than me weigh me. And they have wheelchair scales at the larger locations, and things like that. That's a big deal, because when I first started Weight Watchers, you'd have to go to a hospital to weigh, and now all of, like I say, the bigger Weight Watcher meetings have a wheelchair scale there. So my goal was to lose 8 pounds, and I ended up losing 37. So and I'm off insulin after 10 years, and I'm off cholesterol medicine, and just feel better.
That's great.
Thank you.
Dr. Radkevich, tell us a little bit about, do you have people coming in saying, Healthy You 52, this is what I'm doing, help me? Or do you have people coming in with weight issues? They're, I think we talk about BMI, body mass index, high A1C, high blood sugar levels, and you have to bring it up. Tell us a little bit about kind of how that journey starts when people interact with you.
Well, I think it could be both. I think before my sort of awakening to sort of obesity medicine and just general weight management idea, most of the time, the only time I realized patients wanted to discuss this when they brought it up to me. And most of the time, there would be specific statement like, well, I gained a lot of weight, and I want to do something about that. And I'm like, okay. And that still happens now. I just pay more attention to that, and I know a little bit what to do. And additionally, now that I'm more aware, I do pay attention more to the weight and the BMI. And I think specifically because of these new cardiometabolic guidelines that I guess there was a lecture last month about, that BMI, which is one of the measurements that we can use, it's a lot less, a lot smaller number that signifies obesity in a person with a spinal cord injury than a general population. So I pay attention to that a lot more. And so it can happen both ways. And I think in my practice, most of the time, I start the conversation at the time of an annual exam And then anytime that anybody brings it up to me themselves, then I continue the conversation.
So, Elaine, you said that for 10 years that you were doing kind of all of the usual medications for diabetes and other health things. Did you have those conversations with your primary care doctor or another doctor, or did you just kind of keep doing the usual thing and then just had this decision to change on your own?
I think I was in denial about being diabetic for a long time, and the medications were controlling it. And I think I got a couple signs from the universe that I needed to make some changes. And one of them, a friend of mine, her mom died from complications of diabetes, and her mom wasn't that old. And she said, why didn't my mom love me enough to take care of herself? And I have an only child son, and that really hit home. And then I met a lady on a train who was in a wheelchair and lost both her legs, to diabetes, was an amputee. And I'm like, okay, I get the hint, and decided, well, maybe this isn't just for me, maybe it's for my son too. And it's funny, we'll do things for our kids we won't do for ourselves. And so I want to be around for him, and I want to be healthy. And he just turned 21, and I'm going through empty nest syndrome a little bit. And yeah, food has always kind of been my coping mechanism. So it's been a real change, but it's people have cheered me on, and I've been really public about it on my Facebook page, and people are like, you inspired me, yay, keep going, and they've done that from the start, and that's really been helpful.
You said a couple things that I'm curious about your experience, Dr. Radkevich, about, one of having somebody else to be like accountable to. I think being accountable to your family, your son is really powerful. Not everybody has those people necessarily. And so I'd be curious about kind of where that comes up for you. Also about kind of that community aspect of kind of, it's not just to one person, but kind of being open about like this plan or this goal. Can you talk a little bit about kind of, do you use those in your practice as well?
Well, I think it would be great to be able to do that all the time. I feel that sometimes medical system is not well set up for this kind of approach to lifestyle changes. And because I work for the VA and we're kind of a self-contained system, on one hand, it's really good. I know my patients really, really well, a lot of them, and I sometimes can I can predict in a way what could be a good goal for my patient. So I give little examples like, well, I know you really, really want to be independent for a long time. You want to, I know that has been your goal for many years. You want to be able to transfer by yourself. You don't want to have your wife help you. A lot of my patients are men. And I can kind of, start the conversation that way. So I can use the word goal and priorities and kind of try and figure out what are the most important things for my patient. And then that starts the conversation, and hopefully I can get some more things like, oh yes, I do want to be able to, ski for a long time. I just started and I have this brand new sit ski, and I want to continue with that. And so I find that people who have goals, who have motivation, whether within themselves or somewhere outside, either children or significant others or anything else, are a lot more successful. I think it's not an unexpected thing, but it's helpful to identify that. And then I often function as the person who then continues to provide this support. Well, let's meet again in a month or a couple of weeks, and we'll figure out how you're working towards those goals, because the VA does not necessarily have, as of yet, we're working on it, a particular SCI specific place where people can go and on a weekly basis or monthly basis discuss these goals and how they're getting to them. So that's how I try and approach this.
Yeah, so it's it's just different pathways to kind of that same idea of, kind of having a reason and figuring out what that is, family, a personal lifestyle choice of transferring independently, being able to do some activity. Probably, I would imagine too, some people even want to get to some activity that they don't even, even maintaining, but trying to achieve it. Did you find, like, what are the things that you've noticed? What are the things that have made it even easier to kind of continue? Because your original goal, you surpassed it, so.
I did. There's things that I kind of forget about too, just like it's easier to breathe and, not losing my breath, all the time, and just being able to transfer easier. And sometimes I'll kind of forget and, really boost myself. I'm like, wow, yeah, woo. Yeah, I didn't mean to push up that high. Yeah, it's just, feeling better and, in clothes yeah, I've gone from like a 3X to a 1X. I'm still plus size, but for me, it's just, it's just feeling better about myself and I'll never weigh what a weight chart says to weigh. They say 125 or something. I think I weigh 137 or something. And so I have my own goal weight. And again, I'm just a bigger boned person. I'll never weigh that. But I think my doctor's really proud, that I go to a native clinic and I've struggled with pressure sores before, and that's scary. And so it's funny what will wake you up and make you realize, you can't mess around with this stuff. I've known people that have died, from pressure sores and, different issues like that. There's just no happy ending to uncontrolled diabetes, and I just realized that. And yeah, but I had to come to my own conclusion on that. I don't know if a doctor telling me that, would have, I knew that, I know that, it makes sense, but it just, when it comes down to not eating birthday cake, when everyone else is, and now I look at birthday cake and say, do I want to be a blind amputee on dialysis? No. I have to be morbid with myself, so.
Those totally work. And I'm actually assuming that part of that training that you got in the going to the obesity conference and other things is that simply telling somebody that it's good for them is pretty much not going to work. Is that accurate?
Yeah, I think, when I said in the beginning, when you asked the question of how do patients come to me, whether they say they want to lose weight or I, identify that, I think actually makes a huge difference. So when a person comes to me, person says, okay, I gained weight and do something with this, I find people are a lot more successful. And I think that is because they themselves have decided that that is important for them at that time. We all have all these conflicting priorities in lives. And when it becomes a priority to my patient, then they are a lot more successful. And so my job is to support and figure out exactly how to get them to the point that they want to be. And it is totally true that when I'm the one who is just saying, oh, we're here for an annual exam and look at that, your BMI is a little high. They're like, yeah, it is. Oh, well, okay. It is, then I think what I try and do is open up a conversation with that. I usually, it's very rarely that I'm able to accomplish that conversation during that initial visit. Mostly I try and just sort of say, hey, you know what, I've noticed that this is happening, and sometimes I try and plug in little medical things. They're not usually that helpful, but sometimes people kind of find little words here and there that they do, and oh yes, I had somebody with diabetes, and let me think about that. And then when we have a follow-up appointment, that's what I usually try and do, like, okay, I've noticed this, let's discuss this again. And they think about it, and then maybe can come back and say, yeah, I thought about it, and that might be a good thing to talk. Or maybe they come back and say, you know what, I'm not ready. And so it's an honest conversation, and I think it's just something that, as a physician, I feel that I have have to start this discussion because, especially because the numbers are different for a person with spinal cord injury and not. If I miss that, if I don't pay attention and say, oh, you know, BMI is 25 and it's still okay, but it isn't. So I think it's my job to actually have that discussion and then support and help identify ways to really get to our goal together, whatever that could be.
And I think that's really powerful. And I think, Elaine, you know, you talked about like dieting was not something that was unfamiliar to you. That was your story. That was your kind of theme song in a way for many years. And so that idea of people saying it's a problem but not really be able to make that kind of switch to really a lifestyle change. And I'm curious about, for you, I mean, you had this moment of like, this had to be different, and you started this pathway, but that kind of big change is that changing from, oh, that cake looks good, to, oh, this is the killer cake.
Yeah.
Right.
Yeah.
And so can you talk a little bit about kind of like, how has that shift happened for you? That, because that's a really big kind of psychological shift from, oh, this is this thing and I could just take medication, and oh, maybe someday, to like, wow, this is really going to be different. And you've obviously seen a lot of pluses, but can you, just share with us?
It's still now a struggle. I have to admit, it's something, you know, now with being self-isolated, you know, with COVID, I've you know, the old tapes start running again, and you know, I'm home, and you know, there's more food around than I'm used to, and when I was at work every day and commuting, and would have a certain lunch every day, and I try to eat every 2 hours if I can, just to keep my blood sugar level and not have it, you know, dip down, and even if it's fruit or some almonds or, you know, something every 2 hours. And so now I'm home all the time, and fridge is right there, and you know, my dad, oh, you want some popcorn? And okay, you know, and just because it's there, and it's just, that's how my family, that's how we're together, is we eat together, and it's always been our kind of, you know, communion, not communal thing, communion, thing, and so it's just how we are as a family. We eat together, and so, you know, it's just my way of being with him. He's 90, and he loves popcorn, and so I'll have, okay, no butter, and you know, easy on the salt, but I'd love some. And I got a Weight Watcher one, you know, it's microwave, you know, popcorn, so it's healthier. And I really involved my dad in it because he's the one who does the grocery shopping. I'm like, you know, Dad, you see what you did? This is all from you. You bought wheat bread instead of white bread. Look, you know, this is all, thank you for. So he really had buy-in too about cheering me on, and you know, saying he was proud of me, and that really, really meant a lot. My dad doesn't say those things easily, and so it was really, you know, getting everyone, you know, involved, and my son, you know, he was helping me out of my van one time when the seat was broken, and he's like, don't worry, Mom, I can bench 250 in weight class. And I'm like, thank you, honey. Yeah, thanks for making me feel like a delicate little flower, you know, thank you. And so, you know, and I saw him another time, he's like, wow, Mom, your arms are skinny, they look like mine now, you know, and so I love my son. But and the filter sometimes is not there. But it's just, my family has been great, you know, as far as those things. And so, again, it's not dieting anymore, because that's how I wish I could go back to when I was 20 years old and hug that girl and say, don't diet. You know, that's going to cause you, because I thought 150 was so huge when I'm looking at these weight charts saying I'm supposed to weigh 120. And so all of these years of, you know, back and forth dieting, and when that's not what it was about at all.
Yeah, it's really, I mean, I hear you saying, it's like, it's really been this kind of constant adjustment to food, and a relationship with food that has to be different, and all of that. And I think, you know, one of the things that we had talked about, Dr. Radkevich, is that it's it's not just food, like just reducing eating is often really difficult for people. And so one of the other struggles that often happens, and I'll ask you, Elaine, too, is just about activity. Like what are the kind of strategies that you typically recommend for people in terms of that kind of diet, exercise, kind of with the focus on health as opposed to a specific number or a specific calorie count or a specific, so can you talk a little bit about that?
Yeah. Well, I think kind of going back to, being a physician, I guess, I think part of the things that has always stopped me from being an effective provider of weight management in general, prior to looking into this a little bit more, is that I have always heard that exercise is essential for weight loss. And I think, and I've heard that from other providers from my specialty, that, it's difficult then to really have a conversation with, patients who automatically say, but I have a spinal cord injury, I can't exercise. And so in a way, it felt liberating when I learned that exercise, as we think of it, is actually quite of minimal, it provides minimal assistance in losing weight. It's not necessary in a way. And so, on one hand, it's a blessing, because then really anybody can think of themselves as a person who can achieve this goal. You don't have to go to a gym. You do not have to, run a marathon or ski or do any excessive, what we think of exercise. And so, it's a blessing, is that on one hand. On the other hand, then it makes it even more difficult, because really then what we have to do is to decrease those calories that go in. And so how do you get there? But I think it opened up my mind to the fact that it is possible to do, that it doesn't matter. You don't have to, do all these special things to be successful. And so I changed the way I view weight loss and weight management, and I changed the way I present it to my patients. And I think I try to not mention the word exercise, really, because I think that carries a certain, flavor to it, that not everybody, likes to exercise. And what exactly does it mean to exercise? And exercising is difficult, and it makes people uncomfortable if they're not really doing that already. And so I've kind of opened up more of, let's do more of a lifestyle goal. I as a physician want to make sure that you are healthy for the rest of your life. And what is important is really eating healthy and having an activity that you enjoy, an activity that does, as a great side effect, provide additional calorie expenditure and allows you to enjoy food a little bit better. So this is how I have approached these conversations of how do you balance what we normally say is exercise, that is just now regular activity, and any activity can make one healthier. And I think I really try and emphasize that what I want is for kind of long-term health. And activity is important not just for weight management, because why do we want to manage weight? We don't want just the numbers to decrease. What's really important is long-term health. It's heart health, it's diabetes, if there is such a thing, for if that's important for the patient, and then just general well-being. And so for that, I think it's a lot more attainable. And I really want for a person to be healthy long-term, to get to the goals that they are looking forward in their lives. And that's part of the discussion, whether it is really something that is very personal, family-related, function-related. I think is then a lot easier to identify.
I think that's one of the things that I think a lot of people get stuck on is like, you got to go to the gym if you want to do this. Elaine, what was your thought about that? Like, I mean, obviously the food thing was definitely a big part of this and really figuring out your relationship with food. But had you previously struggled with like, how am I going to actually exercise? And I mean, from what I remember, you like it kind of went in, as you felt better, you did more, right?
Absolutely. And I think I used the fact that I couldn't do a lot of typical exercise as an excuse not to lose weight. Well, how much am I going to lose anyway? I can't exercise, if that makes sense. And so any excuse, that you can come up with to, blame the weight gain. And so I think, just realizing I was going through a financial time where I had to do personal bankruptcy, and I felt like I didn't have a lot of control over things in my life, but I could control what I eat. And there was something that was so empowering about that. I think that's one thing I can do. I can control what I eat, because they talk about, airplane, put your own oxygen mask on first before you help others. And I knew that I could do that. And that was such a big part of it. And I'd take my dog out for a walk, and I remember them saying in, the diabetes education class that you take, that your blood sugar can remember exercise up to 8 hours after you do it with your, and I mean, it's like things like that. I mean, it doesn't take that much. And just getting out in the air and saying hi to people, and I live in a really dog-friendly area where people are taking their dogs for a walk, and he loves it. And again, I'll do it for him, but I won't necessarily do it for myself. But my dog loves going out for a walk so much, that he gets so excited. I think he's gonna, implode. But it's, I'll do it for him, and just getting out, doing some hills, and maybe going a little, area that I wouldn't normally go, but just to get my heart rate up a little bit. That's been my main way of getting exercise.
Yeah, no, but I think that's exactly what you're talking about, right? It's those, just the, as you feel a little bit better, you can do a little bit more. And as you do a little bit more, you kind of push yourself a little bit, try and find a different route, try and do a little bit more, which is wonderful. I'm curious about, we talked a little bit about kind of the somewhat of a psychological struggle with weight loss. And I'll also ask about kind of just any concerns in terms of medical issues with weight loss. But for you, kind of, what are the things that you kind of felt like you lost other than the weight, or felt like you missed with the weight loss? Because that's a lot of reason why sometimes people maintain weight.
Yeah. Well, I really thought, 35, 37 pounds, whatever, after COVID. I hope it's still 37 pounds. I haven't weighed myself in a while. I hope you don't have a scale here. No, but yeah, I didn't realize there would be any type of mourning, to weight loss, but my weight and making jokes, self-deprecating humor has just been a really big part of who I am. How are you? Oh, overweight and underpaid, just jokes, like that, but there's still kind of a little bit of a stab to yourself. That's always been my way. And so, not doing that, to myself anymore. And my clothes, didn't fit anymore. And it was finally my hairdresser. She's like, would you stop wearing your 3X clothes? They look ridiculous, and I'm like, okay, and so, yeah. And so I started buying, clothes that fit. And then it was hard though, because I really liked my clothes. And, I'm just known for my purple sparkly things, and so that sounds like a weird thing to mourn, is your clothes, but that was weird. It was hard to get rid of those. But I'm like, well, somebody needs those right now. And so that's okay. This is a good problem to have. And so, just every paycheck, I'd maybe, buy a new top, or, use that as a goal. Just if I lose a pound this week, then that's how I'll treat that'll be my treat, is to buy myself, a top, or get my nails done, or, something like that, because it gets harder the longer it's harder to lose, it seems like. And maintenance has been hard too. Sometimes it's harder than losing the weight is to maintain, because you can eat more but not too much. You don't want to lose, but you don't want to gain, and finding that right balance, has been tough. But yeah, it's been different. And my life isn't dipped in glitter like I thought it would be. If I was a certain, weight or size, or, I've always wanted, you talk about, for an event, like I always lost weight after a high school reunion, but not before it, because maybe the pressure was off, and then I would, lose weight after. And so, yeah, when you're not doing it for aesthetics or looks, but just for health, yeah, and then all of a sudden you're there, where you thought all your problems would be solved, and everyone who didn't love me before would love me now, and I would have no problems, in the world, life goes on.
I was going to say it's a protector and an excuse, explanation, and I think those are really powerful things that we often forget about in that process.
Yes, absolutely.
Yeah. Do you run into those with patients, and are there any other medical things that people need to even be thinking about or be aware of?
Well, quite honestly, I can't think of too many problems with weight loss per se, if it happens in a kind of a generally good, slow way, which is how I would like. Sorry, I tend to slam this, I feel, microphone. I apologize. So, my goal, because it is really more of a lifestyle, long-term changes, I really feel that it should be a fairly slow process. But when we do make changes to the weight, I think it's important to remember that very important things might change, like wheelchair seating and positioning, and the cushions might need to be readjusted, because slowly but surely there will be a difference. And then there might be a risk of damage to the skin. That's really the major one that I can think of, because in the VA system, I'm sure it's a little bit easier to change equipment, but in the real world, when I hear you can only get a wheelchair once every 5 or 10 years, when you need a new one because you really need a smaller one and you can't get them, then I think it's a risk. But other than that, I think in general, weight management is a great goal, and I commend you for doing so great with it, because I think you really exceeded the general medical expectations.
Thank you. Appreciate that.
Elaine also brought up the issue of maintenance, and in your work, how do you address maintenance with people? How do you help them to kind of figure out? Because I've heard that a lot, Elaine, of that struggle with, like, you have the goal and you work towards the goal and you set it and you've achieved it, and then what, right? And that yo-yo issue, or that kind of steady creep back to higher weight or less activity, or all those kind of things. So what kind of strategies do you use with your patients?
Well, first, I have a discussion that it is something to be expected. It's called kind of weight loss plateau. There are kind of physiological reasons for that, in addition to just, having worked so hard and decreasing all those calories and increasing your activity. You do lose weight, and then there is usually a plateau, and there is an explanation for that, which is really more of a metabolic one. That there are some numbers to it that I don't necessarily want to get into it, but basically the more weight you lose, the less of the energy your body needs to expand. And so when it happens in about 3 to 6 months into the weight loss, and so after that, you kind of are faced with the same situation as you were before you started losing weight, because you either need to decrease the amount that you're eating or increase the activity. And so if the activity is already maxed out, because sometimes there's not a lot of activity options that our patients have. So then The problem, again, is the calories, and so you have to decrease them, and it is not easy. So I try and have this discussion that this is something that I expect to happen, and if there is a possibility of increasing activity, that is really one of the key factors in maintaining weight loss and achieving more. Earlier I said that activity or exercise is not really been shown, or rather it provides minimal additional help in losing weight, but it is known to be key in actually maintaining weight loss or achieving more weight loss. So at that point in time, I explore options of, well, so how are the goals going? Did we get there? What else are you looking forward to doing in your life? Can we get you there and increase your activity at that point in time? And I have the luxury of having very easy access to wonderful therapists, occupational therapists, physical therapists, recreational therapists. You know, the VA provides options for recreation that if weren't really that interested before, but now the weight is a little bit less and the person has actually explored the idea of being more active, maybe we can find more activities. And when you're doing those activities, you might not be eating as much. So it just kind of goes hand in hand. But that's been my approach.
I think that's really important to emphasize, is that plateau happens for a lot of people. And it sounds like that happened for you too.
Absolutely.
And that once you get past that plateau, you have to do more work. It's not just the ride it.
Yeah.
And I think that's probably, I mean, one of the things of having that knowledge and expecting that, in some ways, I would think makes it a little easier than feeling like, but I'm doing all the things I was doing before, but I'm gaining weight again. How frustrating is that? Because I do think that's where people get discouraged, and then they just say, oh, well, you know, I did so well, forget it. I'll just give up now and kind of head back into my usual ways of not doing as much and maybe eating too much or eating not the greatest stuff. So you also mentioned, you know, just the use of PT, OT, recreation therapy to try and come up with great strategies for activity. Elaine, did you need to go into any of those and get ideas, or did you already kind of have, I mean, you talk about like just being outside, being with your dog, those kind of things. Did you need a program, or did you kind of just come up with it? Because I think people do both.
Yeah, I kind of just came up with my own. I, you know, have some friends in chairs, and we'll go out dancing. There's a band that we like to hear, and I mean, dancing is something you can just do at home, you know, and just, you know, it's just kind of fun to do, and you don't really have to think about it. You know, you just put on a good song and just go for it. And but yeah, I've never been a really physically active person, so no, I haven't. But I know that there's a lot of videos, you know, for exercise for people in chairs.
And we just put out an email about those, a few of them. There's lots,
great,
but
great. I understand there's yoga for people in chairs, and that's something I'd be really interested in too. So, yeah, it's but yeah, it's not something I formally have gone out. You know, I have been a member of the Y before. I actually worked at the Y, and you know, they have the wheelchair lifts, and so swimming is really amazing. You know, even though I can't kick, my legs are really happy, you know, just because it's the only time I'm off of everything. You know, when normally I'm sitting or laying on some part of my body, it's an amazing pressure release, you know, to get into water. And but it's an ordeal, you know, it's an ordeal to do it. And so I have big hair that I don't want to get wet, and you know, just yeah, I need a suitcase of hair supplies, you know, to take with me. So yeah, it's a big deal, you know, to do that.
And I think, Elaine, you're so right, because I think exactly that. Like, if people say, well, here's the thing that would work, and if it's the thing that is like the least interesting ever, like getting wet, messing up your hair, having to change into a swimsuit, then no, it's not going to happen.
Shopping for the swimsuit.
And similar to like even going to a gym, right? Or for some people, even just going out in their neighborhood. So you got to find the thing that works. So I love the idea of you know, dancing, whether it's out with friends or even at home, or just even getting the dog and going out and expanding. And I'm sure there's lots and lots of other things that people have come up with.
He's my antidepressant too. I mean, I got him for my son, but I kind of forgot we had cats before, and cats kind of love you on their own terms. And my dog is just everything. He's my significant other. He's been
awesome.
amazing. And again, like I said, I'll do things for him I won't do for myself.
Yeah.
So yeah, he's been great.
Yeah. So I want to make sure that I get the advice from you all. So Dr. Radkevich, what advice do you think is the kind of key things that you want people who are watching tonight to know about kind of weight loss, lifestyle change, kind of healthy behavior to get you to the next level?
Well, that's a loaded question because there's so many answers that I can give. And I think what, I've kind of touched upon, just the idea that weight management is not anything that is a prescription. So we've talked about kind of lifestyle changes, and I think I mentioned the fact, just being aware that exercise, whatever that is not, it doesn't have to happen. I think healthy lifestyle, so any kind of activity has to happen, but that would be really good if it happened. But really, weight loss, if that's a goal, is possible without that. I think it's really important. But then, in terms of being a physician, I think a lot of the times when somebody comes in to see me, they want to hear some sort of concrete ideas. Like, what is it, great that you want me to come up with a life goal. I'll work on that later, but I'll see you in a month. What do you want me to do? Okay, so there are usually a couple of things that I kind of recommend and sort of I start with. If a person is interested in numbers and has apps and likes to do food labels already, then I do recommend some calorie counting. Just any phone has an app you can open and just see what's in there. Usually they're designed kind of in a friendly manner to put in what you're eating, the type of exercising activity that you're doing of your choice, or no activity. And then, it sets the goals for you. They're not ideal for a person with a spinal cord injury, but it's somewhere to start. So that's one way. So for people who are already interested in that kind of stuff, for people who really want more of a general advice, I think kind of go through maybe few points. So number one, I would say to increase some good things. For example, eat more fruits and vegetables, okay? Increase water, and then increase intake of good fats, such as fish or any kind of seafood, nuts, so kind of more of a different style of fats and protein. So those are the three things that can be done in addition. So add more things, more water, more good protein and oils, and then decrease all sort of additional sugars of any kind. So some people do great with just not drinking sugar-laden drinks. No sodas, even if they're artificially sweetened. So any sweetened drinks, out. Or even less by a drink per day would be great. And then the last point is really, I think works also really well for some people, is just decreasing processed foods. So any food that has more than 5 ingredients, less of that and more of the first 3 things, such as fruits and vegetables, more water, and good oils and protein like fish. So those are kind of more of a concrete steps that I like to suggest if somebody's really looking for things. Okay, I go home, what do you want me to do? And then I'll come back in a month and I will tell you whether or not it worked. So.
That's great. That's great.
I absolutely agree. With my program, you don't have to count fish or white meat chicken or turkey and yeah, fruits and vegetables you don't have to count. So it encourages you to eat a lot more of those types of things. And so, and I just remember complaining about how expensive, some of this stuff is, but I would spend that on a pizza, and so you have to kind of, to buy, what a great time of year right now that we're going into summer with all the great fruits and vegetables and the cherries and the grapes and, things like that. And if I have them and I wash them and I have them available in the fridge, then I'm gonna eat them. They're there, and instead of chips, I try to eat baby carrots, so it's still something crunchy with a sandwich. And yeah, it's just, I know that I feel better. I do not feel good, when I eat McDonald's, and I know that. And it's not like that I don't ever have McDonald's, because I do. I want their fries, sometimes. But, I don't have them every day. And there has been nothing that I have said no to. I just, think about it in a different way. And an apple can be a treat. I like to lay down with a really good crispy apple. We live in an area that has great apples, and that's a treat to do. So, and just starting where you are, starting at age 52, I just thought I was too old, and I just turned 55 this month. It's alive and thrive at 55 is my tagline this year. So yeah, I'm just going to keep going, and because yeah, I want to live. We used to not live this long with spinal cord injury. It's been, yeah, it'll be 38 years next month. That I've been in a chair, and so yeah, I kind of want to live.
Yeah. Can you talk just a little bit more about you mentioned Weight Watchers and counting. Can you talk just a little bit more about kind of what are the things, because it seems like they're kind of a consolidated grouping of a lot of these recommendations.
They are. Weight Watchers is great. It's based on points, and then foods have point values. And so the healthier foods have less points, and then the higher ones have more sugar. And and she talked about avoiding sugar, and with being diabetic, obviously that's something that I've had to become really aware of too. And having I tend to have bladder infections and UTIs. And I remember my doctor saying, bugs love sugar, so of, not trying to eat a lot of sugar, because you can get more infections or have trouble getting, rid of the infection. So I try to remember that and have healthy sugars, like from fruits instead of candy and sweets. But I forgot your question.
About Weight Watchers, just
Weight Watchers,
the program and kind of how it combines some of these things.
Yeah, the points make it so easy. And again, it's an app, but there's other apps too, like you mentioned. But you just have to scan it with your phone, a barcode on any food, and it comes up with the points. So there's 3 different programs you can be on based on, you choose which one you want. It's different points. You lose weight all the same way. I'm purple. Of course, I would be purple. And so it's, there's a lot of 0-point foods, and then the higher point foods, you only get, a limited amount of those. But, I'm to the point where I'm so used to the 0-point foods that's what I gravitate toward now anyway. So it just works for me. And there's different platforms. Right now it's a virtual workshop that's all done by Zoom, and you meet with a leader, or you can just do it on your own. They will eventually go back to an in-person workshop, but the Zoom classes have been fun, and I need that community myself, and being accountable to someone weighing me in helps me. It just having them weigh me helps me, and the really big thing is tracking and writing down what you eat, getting down to basics. So if I feel like I'm creeping up, okay, what am I not doing? Oh, maybe I'm not tracking and I'm eating, extra food, or I'm not drinking, as much fluid as I normally do, or yeah, so they just have some very basic things that you just go back to if you feel like you're starting to, wander off. And it's funny, tomorrow's a new day.
Yeah.
If I don't have that cookie I wanted, I'll eat it tomorrow then.
Yeah.
And I'm not feeling like, oh my God, I have to eat this because tomorrow I'm going to be on a diet. It's not like that anymore. If I don't have it today, I'll have it tomorrow if I still want it.
Yeah.
But yeah, it's been a great program. And in full disclosure, they've hired me as a Weight Watcher coach. So I'm a leader, and I'm going to be having my own workshops.
Wonderful. Congratulations.
Thank you.
Yeah. I think it's really important. There's a lot of different pathways, and I think that's what you guys have really talked about. And there's great things with some of the groups, and especially if you want community and kind of structure, and people can do it on their own and just monitor it themselves, and kind of do it in isolation. Nobody has to see that scale necessarily. Maybe your doctor does. Occasionally.
Sometimes.
But this has been great. So I want to turn it out to our audience to see if there's any questions that have come in. A bunch. It sounds like I'm getting the nod. So what questions do we have coming in? The question was about accessible scales. Like, people want you to lose weight. They talk about losing weight, but not even all doctors' offices or hospitals have wheelchair accessible scales. You mentioned your Weight Watchers group does now.
Yes, they do.
For you, I'm assuming the VA has easy access to a wheelchair scale.
Well, yeah, I think it's a great problem for patients, people who use wheelchairs all the time, because one of the cornerstones of losing weight, one of the advice that people give all the time is that you should take your weight daily. Well, it is not possible. So what do we do then? And I think that's where, there are two cornerstones. If we start getting technical about these things, as a doctor, I will eventually become technical. So weighing is one of the ways, but then actually looking at the daily calorie intake, so using those apps just one of the ways, but actually just writing things down, knowing what you eat, basically paying very close attention to how many calories go in is another way. There's research that backs up that both looking at the weight on a daily basis and looking at calories, what you take in and what comes out, helps losing weight. So it is helpful to know what the weight is, but it is not 100% necessary. Again, I, in my practice, really advocate that my goal is not to see the numbers go down, even though that would be great, but it's really changes in lifestyle. Because if there are lots of sugary drinks going on every day, just cutting those down will help with being healthy. If there is no activity going on, adding some activity, whatever that is, I think just going outside and just leaving the apartment, especially right now in these really, really difficult times, still helps. And so for me, that is really the goal. And then kind of losing the weight is a little prize. The light at the end of this, very difficult tunnel, that, if I see that there is a change in weight once a year, that's great for me. Really, what I want to really emphasize the importance of healthy lifestyle. Health is something that will stay with us long term, and weight is just one way to get there.
Right. Yeah, my A1C was below 6 afterward, and things like that. That's what I was going by, more than the weight. And it was not a big ticket number that made huge changes. I actually, I blacked out one time from not eating, and I was on my way home, and I just was still on insulin, and I was driving and had an incident. So yeah, I had to be really in contact with my doctor to keep taking my A1C and being really aware of it, of taking my blood sugar so that that wouldn't happen again, and you know, eventually, you know, getting off insulin entirely and just controlling it by food. But yeah, it's, you know, it's something you really have to work with your doctor on, because it's bigger than I thought it was going to be. Yeah, yeah.
Yeah, this is another question. First of all, thank you, Elaine, for your openness and sharing your experience. Very much appreciated. And you talked a little bit about working with your doctor. If you want to find out about your own cardiometabolic health and potentially start some kind of health goals, who should you start with? An SCI doctor, primary care doctor?
I don't see a physiatrist. I haven't in a long time. I'd like to, but I go to a native medical clinic, and I have a great doctor. You know, with my financial issues, I've just haven't really seen any specialists in a while, so I've worked with him, and he's been great. He's been great, and I tell him what I'd like to do, and we set goals together. Like you were saying, it's really important to have a goal. I always, because depression is something I've always fought with too. I take antidepressants, and you know, they were always talking, anything that I read about or with a counselor, of always having a goal or something to look forward to. And so for me, that personally really has helped a lot. But I have done that with a doctor, and again, it hasn't been a specific, you know, spinal cord injury, you know, specialist or anything.
Yeah, I think, can you speak to that a little bit too? Like, I think there are things that you've talked about that are really very specific to spinal cord injury, and other things that are really the kind of more of a primary care internal medicine focus. And so, you know, at what point do you tend to stop and hand it over to internal medicine? And when do you think it's better to see a spinal cord injury physician?
So one little disclaimer is that because the VA system is a little different from general non-VA medical system, I actually serve as a primary care provider to patients with spinal cord injury. I am a physiatrist, so I don't have a background specifically in primary care, but that's what I do. I'm an assigned primary care provider. So I think in general, it would be okay to start with any provider, I would think, that you have a good relationship with. Somebody that you want to go to and say, you know what, I've been struggling with this, or it's just a new goal, something that I've heard about. You know, what are your thoughts on this? And I guess in a way to probably be prepared that the provider might not have all of the information. So they might have some information, but depending on who you go to, you know, if it is a general medicine provider, they might have general statements like, you know, what I suggested, you know, cut down on the sugars and drink more water, but maybe not really be that knowledgeable about activity. So, you know, if that is the case, then actually being maybe, I guess, kind of proactive and saying, you know, I do know that I can still do really well with increasing my activity. What would you recommend? Can I have a prescription for physical therapy in, you know, my clinic or whatever it is, if that's something that you're interested in? And if not, you know, I think there are a lot of people out there who can do more of like a peer support situation and suggest, you know, this is what has worked for me. This is how I've done this, and it has worked for me as a person, either with paraplegia, tetraplegia, or just spinal cord injury. So I think just a starting point, reaching out to whomever it is that you're comfortable with discussing this and figuring out, because it's a big goal, right? So it is a lot, you know, it's gonna stay there long term. So it's gonna be back and forth and coming back and readjusting and making different goals, small or large.
That's great. So another question was, you know, we've talked about how the BMI numbers are different, but are there specific issues about like metabolism or other changes after spinal cord injury that, like, I guess, why is BMI different, and kind of what implications does it have as we think about weight loss?
So, it's getting more into the weeds of things that I me being a physiatrist, and I'm not a specialist specifically in weight management. I know some things, but not all. But what I do know is that it is really changes in lean muscle mass after a spinal cord injury. There is a decrease in muscle mass, and muscle is really what makes this metabolism fire and use up the calories. So immediately after a spinal cord injury and in the first year, there is significant loss in the muscle mass, and that's when a lot of the weight gain initially happens immediately after spinal cord injury. There's also replacement of the muscle mass with some fat tissue. So it's kind of I guess the way I like to think about this, and an explanation that there are sort of metabolic factors that make it more, that the weight comes on easier, and it is more difficult to then lose the weight. Was that?
Yeah, I think so.
Okay.
People can let us know if we didn't quite hit it.
Okay.
One more question for you. In terms of cholesterol and triglycerides, like, should people just be taking a statin even if it's quote unquote not required? Or is that something that you want to be very careful not to take medications unless you meet the specific kind of problem areas for cholesterol and triglycerides?
So I generally would not recommend starting a medication of any kind if it isn't really required. So I'm assuming that there may have been a conversation, I guess, at some point in time for this person with a provider that said, okay, so there are certain numbers, and usually these are the elevated cholesterol, elevated lipids that prompt the provider to say, okay, this is a good time to start discussing medications. So I think the guidelines, most current up-to-date guidelines for management of dyslipidemias in general, that's kind of an umbrella term for lipids that are either too high or sometimes the good cholesterol too low, is that initially there are actually equations that a provider can use to figure out what is the risk for cardiovascular disease. And why do we even care about cholesterol? Really, cholesterol by itself is just a number. But what we care about is that there is an association between high cholesterol and increased risk for cardiovascular disease. And that's another umbrella term for heart problems, strokes, peripheral vascular disease. So we know that these higher numbers have association with higher cardiovascular problems. In addition to those just numbers, there are other things that we usually need to take into account. Some of those things can be modified and some of them are not, such as age and sex. Women usually are at all sorts of different metabolic kind of profile. Then high blood pressure, diabetes, and smoking. Smoking is one of the things that can be changed. So all of that is taken in the account before a decision for taking medication is taken. So we now have sophisticated equations that kind of help us make a decision on when a medication should be started, with a caveat that we're fairly certain that those calculators for the cardiovascular risk actually underestimate the risk for people with spinal cord injury. But we don't have a calculator that is specific for a person with spinal cord injury. So the first step usually is to try lifestyle changes. So that's what we've been talking about. What we really have been discussing goes under the umbrella of lifestyle changes. That is trying to increase activity to become healthier and make healthier food choices. That is step number one, most of the time if the risk factors are not too high. But there are some times when the risk is already high enough that the medications are recommended. Statins are the specific medications that are known to decrease that risk. And so that's why they're recommended. So to answer that question, I'm not certain I've covered all of it, but if a physician has mentioned that a medication is not required, then I'm assuming that maybe there is a state when the numbers are high, but the risk is not high enough. And I think then it would be a good point to have the discussion. Okay, why would you want me to start this medication, doctor? What else can I do before I start the medications?
Right.
Can we wait a couple of months if I make certain changes, check the lab again, and then have this conversation again? So it's a very long-winded
No, I think it's really thorough.
Answer.
I appreciate that because I think it is really complicated because, I think some people just look to medications as kind of their fix. And I think as, and kind of your, like, put it out of your mind because now your numbers look okay. And so you don't have to think about it. But oftentimes that doesn't come without some concerns too, some side effects. And especially I would think that risk, the fact that we don't have the calculator, that we don't really know impacts of some of these medications after spinal cord injury is kind of an area of concern too. So,
well, I think statin, just to sort of go back, that statins are okay to take when they're indicated because these are the medications that have been proven and studied, and they do show that they decrease the risk.
right.
It's the medications that we are more cautious about are the medications that are actually for weight loss, and that's not something that we want to necessarily start with a person with a spinal cord injury. But statins are okay if they're
if they
indicated.
meet them. Yeah,
Yep.
if they fully meet those criteria.
Right.
That's great. So the question is whether there's any side effects that are different in people with spinal cord injury from some of these meds that people get for cardiovascular health issues.
So yeah, statin, it's one of them. It's like a really well-known, well-studied, long-time used medication that if their indication is there, should be used. I think that's safe. The side effects would be the same. Often these do include, rarely, that something that can happen but does happen rarely is muscle pain and associated weakness. So it's something just to be aware that if it does happen, providers should be made aware of. But it's maybe some people are worried that it would be harder to tell if a person already has some weakness, but I haven't had too many people that actually did develop problems. So side effects are the same as with general population. The other cardiometabolic medications are the ones used for high blood pressure. In general, side effects are the same. There are a huge number of these medications, so I'm not going to go over all of them, but there's one kind of subset, which are the diuretics, which even though the side effects is really the same, that person has more diuresis, so more urine comes out, it is more difficult to manage for somebody who has a spinal cord injury and uses intermittent catheter. I think if somebody has different type of bladder management, it can be used quite successfully, and these are very good medications, but it's just something to remember that could be different, and a provider who does not often work with somebody who uses intermittent cath might not recognize that as a problem. It's just that you will need to pee more and cath more, and that might be difficult to do. I guess the other type of medications are medications that are used for diabetes. And again, there are a multitude of them. Some of the medications, they do affect bowels. And so those are the ones that we need to be more careful about. Again, the side effects in general are the same. So some of the medications, for example, metformin, which is a first-line medication, can cause diarrhea. Whether or not somebody has a spinal cord injury, diarrhea might happen or might not. But a person with a neurogenic bowel might have more difficulties managing the diarrhea, or even if it is loose stool, or just changes in the pattern of the bowel movements. If they are not the usual type, it will be more difficult to manage. So the side effects are the same, but the outcome might be a little bit more unpredictable. On the other hand, these are very good medications. So I usually say, yes, we should try these medications. We should try a medication that is first line and see if there is a side effect, because not everybody has those side effects. So there are lots of new medications for diabetes that are coming out that are really good. They decrease not only just the numbers in terms of hemoglobin A1C and the sugars, but they decrease other things like cardiovascular disease related to diabetes. So it would be good to try. The other kind of the last subset of medications is the medications that are specifically designed to lose weight. And those are the ones that we really have to be careful about because they have not been studied in people with spinal cord injury. So we really have no data. We don't know that they would work. We don't know what outcomes we will see. And they might have side effects that are different and unpredictable. Another caveat with that some some of those medications are the same that are used for diabetes management, such as metformin or some of the newer ones like liraglutide. They're wonderful diabetes medications, and again, they could be tried for diabetes, but I personally would not start them specifically for weight loss.
So, Elaine, Dr. Radkevich, thank you so much for joining us tonight. Really appreciate it, and thank you all for watching.
Thank you.
Thank you.